I attended a integrated care board on this week, and at it we had a number of issues that were presented and discussed, and the first one up was dentistry. We had a significant presentation by two very able gentlemen, and I'm hoping our editor can just put a bit on this to give you a flavour of what it was about. But fundamentally what they said was, back in 2006 under the Labour government, there was a new dentist contract drawn up, and many people expressed concerns about it when it was introduced. Then coming into 2009, it was agreed that it wasn't fit for purpose, and then all sorts of things happened. But here we are in 2024. The NHS itself has just decided that the integrated care boards, and this was late last year, they would have the responsibility for sorting out the chaos that has resulted from the payment and the contract that the dentists were obliged to sign in 2006. So really it's quite a dereliction of duty over quite a number of years. But have a look to see how here in the Integrated Care Board of Suffolk and North East Essex is proposing to address the issue. Now what they are saying is that over a 3-year period they were hoping that they could increase those of us who have an NHS dentist from just around 40% back up to 55%, which was actually the proportion that existed before the pandemic struck. And as you know, the pandemic itself had a major impact on dentists and dentistry. Okay, have a little look at the beginning of the presentation of this particular subject at the ICB board meeting.
And really pleased to welcome Nick Barker to the table as well, and we're going to give a joint presentation, and Nick can introduce himself shortly. Obviously this is a really important day for us, I think, as the Integrated Care Board. We picked up responsibility for oral health commissioning last April, and this plan represents a combination of lots of work that we've done with partners, and particularly the team led by Greg Brown, and we're really interested to hear feedback from the board, and we hope this sets us well for the future. So Nick and I are going to take us through the slides, so we thought we'd perhaps speak for about 25 minutes, 30 minutes, that's okay, to colour in the plan a bit, and then we're really pleased to develop that further. So hand over to Nick.
We have a situation that is broadening as to health inequalities as related to oral health. In part, that is related to the way NHS services have historically been contracted. What we do know is that the two major dental diseases are tooth decay and gum disease. Both are non-communicable diseases, and in actual fact, gum disease is the 6th most prevalent disease in the world. They both react well to prevention and can be achieved. So what we're really looking to do is find some treatments for those health inequalities and move on from there. So Peter, if I can have the next slide. So children's oral health is generally strong in Suffolk, as we've stated, but there are deprived populations, and this is some of the issues that we have in that poor oral health is directly related to low socioeconomic groups, and we do find that the tooth decay is the #1 reason for young children to be admitted into hospital to undergo general anaesthetic. Again, I emphasise the fact that this is on something that is a preventable disease and something that we need to move alongside. Adults' oral health, similarly, there are strengths and weaknesses, and across evidence of active decay, you'll note on the slide that certainly in Essex there's a higher level of active decay within teeth. Fortunately, the oral cancer rates across SNE are lower than average. But on the right-hand side of the slide, the key element to note, as far as the Integrated Care Board is concerned, is that if we're going to use prevention of these diseases as a key element to improve things, by preventing the diseases, it has a bi-directional effect, and there's a very strong evidence base to this, such that, for example, poor diabetic health is if we improve oral health, the same for cardiovascular disease, dementia, low birth weight babies, etc. This is all because these have inflammatory markers. Oral health has a high level of inflammatory markers within the bloodstream, and therefore other diseases can be directly affected. Thanks, Peter. Thank you. My eyesight's not that good, so I'll move over to Peter for this one.
Yep, we just wanted to include this slide just to illustrate and just remind everyone that the NHS dental care is not free at the point of use for the majority of the population, and there's also a strong private market, and so that in terms of people's access to dental health, that drives inequalities between populations. But it also, for the working population of the dental workforce, they have a really active choice between working in an NHS setting or working in a private setting. But I just wanted to remind everybody we are dealing with something slightly separate in terms of what we're used to dealing with in our normal NHS commissioning environment. These graphs give an indication about the amount of people who are able to access NHS dental services. And the graph on the left shows the percentage of the population who've accessed a dentist in the last 24 months. And that was at 38.7% of our SNE population had been accessing NHS services. And that shows a reduction from 51% pre-COVID. And so COVID definitely had a massive access impact, and dentists are catching up on those contacts with our residents. On the right-hand side, you can also see measures of the courses of treatment that are being completed and the units of dental activity. And I'm pleased to say that if you take the percentage of population that's have accessed an NHS service, it's gone up from 38.7% to 42% by by October 23. So we are seeing a rapid increase in the amount of NHS access, but it's still below that 51% that was the pre-COVID statistic. But again, important to demonstrate that we're not necessarily providing a universal service in terms of everybody looking to the NHS for their dental care. This next slide just illustrates the contracted activity that we have in place. And Nick will talk in a moment about the sort of impacts of the contracts for the dental providers. And what you have here identifies the number of providers that we have in place and the units of dental activity, which is essentially one dental health check counts as one unit of dental activity. And there are different bandings of work done by dentists that count as more than one UDA. And you can see that across SNE for 22-23, only 74% of the contracted activity was delivered. 26% wasn't. So we've got contracts out there, but the dental practices aren't able to generate the UDAs in the way that enables them to receive income. And we'll talk much more about the nature of the contract. We also know, with regards to the experience of the wider NHS, that this is a major reason for people calling NHS 111, the 2,000 contacts a month, and that could be people trying to find a routine dental access point or with an urgent dental problem, and we'll hear from Health Watch colleagues a bit more about that later on, where people are trying to get urgent dental access and not able to, and using 111 as their main reason for main route in. And we're also seeing presentations in A&E and in GP practices because the dental system isn't functioning as it could and should be doing. So from a patient point of view, this has significant impacts, also from their wider well-being and general economics. Thanks.
Thank you. So why has it worsened? Well, the background is going back to what we've shown in the last few slides. A key element was the way the contract worked. The contract came in 2006. By 2009, following a report called the Steele Report, it was declared unfit for purpose. There's been various reviews back to those original points, and indeed last year there was a Health Select Committee that met over 2 sessions, receiving evidence from various experts. I have to declare I was one of the experts involved in that. and there was a report released in the middle of last year that again reiterated the fact that we actually need innovation and reform of the contract. And there has been a further review only last week, again over 2 sessions, which came to a similar point. So the issue is, as the slide talks about, is that the current system, the unit of dental activity, is the only measure that we have in the current contract, which says if you come to a dentist and you have something done, that earns a unit of dental activity, a widget. So it's all about performance. So it's driving teams to perform dental services rather than work under what might be termed best practice. The unit of dental activity is effective for patients who are regular attenders, who come in and they just churn good oral health. We can tick off a widget, it's easy to do, but if you've got somebody who turns up who needs 10 fillings, several extractions, a new denture, etc., then the current contract of earning widgets is nowhere near so good. I.e., if you have 1 filling done, you earn 3 UDAs. If you have 10 fillings done, you get 5 UDAs. And yet it's taking multiple more times to do it. So this is where we're looking at. The other issue is that the contracts are, in the main, long-term contracts. GDS is an in perpetuity contract, a general dental services contract. So those contracts continue until either the practice chooses to offer to hand the monies back, or the ICB can organise how exactly that may be procured elsewhere. The good news is that that is now under a change, and that the ICB has greater strength to take back long-term underperforming contracts and turn it to somewhere else. On the right-hand slide, we've seen the fact that we know that the people performing dental services are reducing, particularly the younger generations are turning away from NHS dentistry to at least an extent where they're only performing part-time and reduced hours. Thanks, Peter. But there are opportunities. We've had various elements come in, particularly some guidance that came in last year from NHS England Central Office that talked about the ability to flex contracts. So this is moving away from the unit of dental activity into a different model, and we can start to use that. And originally it was said it was 10%. The new commissioning contract says it would normally be around 20%, but it can go upwards of 20% as well. And what we really want to do is use something whereby and other elements that suit other groups, both working inside of a practice and in outreach services. Further, there's also guidance that says historically it's only been the dentist that could run a course of treatment. You could get other dental care professionals. This is the dental nurses, particularly upskilled dental nurses, something like a nurse practitioner. We have hygienists who carry out treatments for gums, and therapists who carry out a wide range of dental treatments, nearly that to the dentists, other than the ability to provide laboratory items such as crowns and bridges and dentures and carry out root fillings. So we've got new guidance that says we can utilise these. If you take that alongside the flexing of contracts, then all of a sudden you have a much larger workforce who are actually able to provide further care. Peter, over to you.
This is these two.
Sorry. I'm a slide ahead of myself. Apologies, sorry. So we've also got other challenges across, rather than just primary care. In secondary care, there are reduced training numbers. We have consultant vacancies. There are limited regional specialties. So we're moving away. And also getting hospitals to work together in acute trust form has been historically quite challenging, both within the hospital as well, between different specialties, particularly medical specialties as well as dental specialties such as head and neck cancers, and then across acute trusts where there might be a hub and spoke model where one has a particular housing for something like oral surgery and another has a housing for orthodontic services. So what there is a specialism in primary care as well. We have the ability to use level 2 contracts. This is something like a dentist with enhanced skills or a special interest, as has been used in the medical models as well. This is somebody's sub-specialism, but that is actually recognised as having sufficient skills that they can undertake more complex work. And there's an opportunity to develop that across many dental specialties, particularly in root fillings, gum treatment, special care dentistry, treatment of children, and the like. So we have an opportunity there, and likewise we're looking to reduce orthodontic waiting lists through the specialists in primary care as well. And there's also currently a review involving Health Watch, particularly in Herts and West Essex, and learning from that to share with the SNE ICB. Thanks, Peter.
So I think what we've done is we've set out what is a slightly grim, but ultimately let's be realistic, situation of what current dental access is like and all the challenges that are in front of us. And we really wanted the board to sort of, as much as possible, immerse yourselves in what the challenges are. And so we're now going to talk about the strategy and what our approach to this is, and really wanting to emphasise that if we're going to make an impact, like lots of aspects of our work as health commissioners, we have to work across the entirety of the oral health continuum, from the great promotion of the right eating habits in preventative terms through to the most specialist care. And we've set out a series of principles that we want to use to guide our strategic approach. And we've not mentioned them so far, but the educational institutions, the universities and colleges are really important in helping us to develop the future dental workforce. And as you know, there's lots of great innovation we'll come on to in a moment. And so that partnership with our universities, our practices, and a preventative whole body approach is what we're looking to take in how we progress with our strategy. This needs it is as a team game, to use some of your phrases, Chair. And so we're fortunate that we have our two regional dental chief officers sharing the lead role. Which is the next slide, sorry. We've recruited 4 senior fellows and mid-career dentists who are supporting us and our neighbours in Mid and South and North and Waveney ICBs. We've increased our team because there's so much work to do here, and we're taking a multidisciplinary approach and working closely with the public health consultant at regional level to look at what our health needs are using their advice. And so we've set out a 9-point programme which we'll give you the headlines of in the next 10 minutes as we take you through what our proposed approach is. If I do one more, then I'll hand back. So back on prevention then. So what's the first aspect of our plan is, as we talked about, is the prevention approach. What we've done with, and I've tried to do with this document, is to give you specific dates that we're holding ourselves to account for certain review dates or certain new services going live, and who the lead organisation is. And there's lots of detail behind this that we have as a work programme that we're looking to with regards to our prevention. But our prevention programme so far involves going into schools, and we've worked with Suffolk County Council and with Essex County Council and taken similar but slightly different directions based on where our conversations have taken us. And just taking Suffolk County Council, we've got a mobile resource that is going into targeted children and family groups and for homeless centres, and we're expecting to have 1,400 assessments per year in those situations where people might not otherwise be getting their dental health assessed. In the North East Essex side, we've done some important work with care homes of training staff to help them understand dental oral health and be skilled to do so. And we've got 6 homes already trained, and we're looking to increase that through this programme and many other initiatives. That's just some of our examples. So perhaps, Nick, I'll go to you to talk about the workforce.
Yes, thank you. So, as Peter's pointed out, we've got some university input. One of the larger issues that we have in east of England is we don't actually have a dental school somewhere which is training undergraduate dentists, but we do have 2 centres now, the University of Essex and University of Suffolk, both of whom are training hygienists and therapists. In fact, University of Essex has the largest cohort of undergraduate hygienists and therapists in the country. So there's an important element there that we can start tapping into. We can look to develop Centres for Dental Development. This was a term developed by the Advancing Dental Care and National Report by, as was Health Education England, which looks at sharing that care across a wider team. And we have aspirations as things such as advanced clinical practitioners, which is something that's in normal medical care, but in dental care we haven't developed that as yet. And yet we have opportunities in vis-a-vis apprenticeships for across various levels. So advanced clinical practitioner is at a master's level, but at an undergraduate level, University of Suffolk are already looking at a level 4 qualification for oral health practitioners, as are University of Essex. So these are people who can go out and work autonomously. I talked about a level 2 qualification just previously, so this is a postgraduate qualification of upskilled individuals, both at hygienists and therapists and dentists. So we can move these into primary care, and their main role will be to actually have the undergraduates being taught in primary care as well as the postgraduates, which will allow us to then increase the number of people working out in primary care. And the very good news is there's a recent report by NHS England referring to provisional registration, which allows overseas graduates to come and work in primary care as well. And that's something that we're also currently working on, so that we can increase the numbers of whole-time equivalents working across the ICB. Thanks, Peter. Yeah. So we've got, there's a range of professionals. I mean, I'll not necessarily go into each one of these, but as I say, we've got across the range a number of people from the normal staff in a dental practice, the hygienists, the nurses, the receptionists, who can then upskilling to extended duties nurses, who can then move on to hygiene, then move on to therapy, then move on to an advanced clinical practitioner. And actually there's work currently undergoing at University of Liverpool, which allows some of their therapists then to upskill to dental training as well. So there's an awful lot going forward that will allow us to deliver this care in a more cohesive, joined up approach, where the right treatment is provided by the right person to the right patient at the right time. And that's really what we want to achieve.
Thanks. So just moving on to some of our improving access actions. This next slide really summarises the most substantial difference that we're making immediately with regards to improving dental access. And one of the massive deterrents that we heard previously about the current contract is that if a patient is of a more complex presentation and is going to take longer to take care of for their health check or their treatment, the UDA system doesn't reward practices for the work that's involved with that. And so we are using the powers of flexible commissioning that enables us to pass additional funds or give greater flexibility for practices to earn their contracts by looking after priority groups. And so we've specified on the right the population who fall into this category. So we're really looking to improve our access by starting with the patients with greatest risk and greatest opportunity to benefit from the right-hand side. We have put this offer out to every practice in SNE, and so far we have got 20 providers who've taken us up on that, and that will mean that we'll be spending £1.5 million with those providers to provide extra services for these residents. This includes opening on evenings, weekends and bank holidays as a way to tap into the additional clinical hours to provide extra services. And so just to give you a sense of the numbers, that will be 230 hours per week of service that is starting in April, and in Nick's practice they've gone live already offering services to these patients. So when someone phones 111 with a really urgent need, the 111 have got a network of providers that they can then direct people to with these high priority needs as our first action that we're really pleased to be taking. We're also looking to make sure that we're asking each one of these practices to take specific responsibility for residential institutions. So we're trying to get to a situation where every care home and every children's home has a dental provider that they can look to say that is their ongoing point of contact for the oral health of their residents. And we have about a third of our care homes will be covered by the end of April once these 20 providers have gone live. We've got and this is a feature of SNEE's dental services. We've got differential take-up across our area geographically. So we've got good take-up in Ipswich and Colchester, and we've got a lot of work to do in the Bury St Edmunds area to increase NHS dental provision. There's lots of other nuances, including Felixstowe and other areas where we've got geographical deficits, which I'll come on to in a moment. But there's a lot of important progress that we're making here. The next slide, and again this is one slide summarising a huge amount of work that sits behind this. We're going to be, we've already increased the minimum price for the unit of dental activity, so the range of prices was enormous, and ahead of the national announcement we moved practices to just under £30 per UDA from what some of them are on £23, £24 to try to retain them, to stop them handing their contracts back, and to give them appropriate financial reward for the work that they're undertaking. We're developing new recruitment incentives to put out to help in line with the national offer to recruit. So it says September 24, but we'll be bringing that forward. And we've got, on the right-hand side, we've done provide an estimate of the amount of activity that we're looking to increase each year. So we're trying to achieve roughly a 10% growth in dental activity over the next 3 years. And that will get us back to fully deploying every NHS pound in the NHS dental market. It's a really ambitious plan that we're setting ourselves. And we can see the range of actions that help us to get there. And whilst we're using units of dental activity as a method of counting, that isn't how we're contracting for all the reasons that we've described before. A key opportunity that we're going to be taking advantage of is around 10 of our contract holders account for 80% of our underspending and underperformance. And so we'll be in contact with those contract holders to agree with them a realistic activity plan. And then we hope using new powers to bring that budget back to us, that we can then fund long-term procurements to bring in new NHS dental providers into the market, which will be a mixture of 5-day procurements and 7-day procurements, depending on the pattern of need. And one of our priority actions on top of the priority access service is to complete a needs assessment, so we can be really clear, we know which geographical areas are the right ones to start in terms of going out to the market to recruit additional providers. We also have the Suffolk Dental CIC, which is opened in March, and it already has a training purpose, and it will be gradually recruiting its staff and will be a key component to also providing additional sessions in this context. Conscious of time, we've got a number of orthodontic providers, and generally the good thing about orthodontics is that the contracts are being fulfilled. So where we are offering units of activity for orthodontics, providers are completing it. But as a result of COVID and demand, we do have waiting lists, and so we are learning from Herts and West Essex colleagues who've commissioned a health needs assessment to work out our approach to this, so that we can make sure that there's covering Suffolk, and this is a long-standing service providing services for people with a learning disability and other needs, and we're working with them to increase their service provision and renewing contracts and introducing additional elements to their contracts to look to increase our capacity in this service. We've touched on secondary care. We've held a couple of workshops with the oral maxillofacial consultants in Norfolk and Norwich, and MSE Trust and Adam Brooks Trust, to working with SNF colleagues to say, so where might we go next to try to address the SNF consultant gap? And Nick started to describe the model that we're looking to try to achieve, which would be for Norfolk and Norwich to be able to recruit consultants who would cover the Suffolk population, operating out of SNF sites, depending on the nature of the activity, and then working similarly with MSE to recruit consultants. And that has the benefit of helping our population access services, but also helping the consultant rota to be workable for the NNN and MSE, where they're trying to get to 8 consultants on the rota for on-call, which will help, we hope, with their recruitment. But it's a really significant challenge in terms of attracting people to the area. Paediatrics is a national challenge, and I've already talked about the additional prevention work we're doing, and one of the ways we're getting into this is to there's be a set of national standards for paediatric practices and child-friendly surgeries in order for us to make sure that it's really important that children feel able to and can access services across our whole geography, and we know that we've got aspects of our geographical area where that isn't the case. I think I've covered off most of these areas. I think the other thing I just haven't spoken to so far is that we've got we're analysing our activity on sort of super neighbourhoods, so to speak, to work out, so what is the coverage across Ipswich, across Colchester, across certain of our patches, to help us work out which are the geographical areas where we need to work. And also, if we've got, say in Haverhill, we're fortunate to have 3 NHS dental practices, and there's a range of care home support to try to bring those dental practices together to think, well, how can they work in tandem with each other? Because a bit like general practice 3 or 4 years ago, there's not great joint working between dentists at the moment, so we can hope to get the dentists to work in partnership where they are offering NHS contracts to meet the need. At this point, perhaps if I just give our final slide, then I'll hand over to our Healthwatch colleagues, if that's okay. Just in terms of the next steps for our plan, perhaps just one more slide on. Oh, sorry. So if the board, we're really looking forward to the board's comments on the plan today. We've raised with our county councils the question of fluoridisation, which has been raised nationally as a potential prevention tool, which is open to our councils and working on a regional basis to take that forward. And we are really interested in people's comments on this plan to help us develop it. And my proposal to you is to come back every 4 months with a really practical description of how we've progressed against this plan going forward. But perhaps if I stop there, consciously talked a lot, and then hand over to our Healthwatch colleagues for the Healthwatch comment.
Peter, Nick, thank you very much. So, Sam, Andy, did you want to come in with some comments before we open up for questions? Yeah. Do you want to grab a mic, Sam?
Although you're all used to me shouting across the piece, absolutely. And you're probably used to the fact that oral health prevention, promotion and education is my favourite topic. So dentistry and access to dentistry has been one of the main reasons why people contact us for as long as I've been involved in Healthwatch. And I suppose there's this reform, but there's also making oral health everybody's business. What is good for oral health is good for health generally. We have a whole wealth of professionals who are talking to individuals, especially those individuals most impacted by health inequalities. So we can make this everybody's business. We can prevent a huge amount of dental disease and decay by working together on this agenda. We have done specific work around the special care dental services in the past, and there's some huge learnings from that we're able to feed forward into these plans. And I've worked closely with Nick in the past to share this learning. And I look forward to being able to share the learning in the West Essex and Hertfordshire area about the orthodontic services as well. We continue to be involved as much as we can because we know this is a priority area. And Nick very clearly outlined the impacts this can have on wider physical health from a physiological perspective, but there's also a huge biosocial perspective to this as well. We're going to be doing some work with our young people over the coming year because the massive impact on self-esteem, self-worth, perception, when you have poor oral health or poor dental health, when everybody they see on TV has great big white straight teeth, the impact that has on your smile, on your ability to chew, socialising, eating out, going for job interviews is huge. So we can really work on this as our whole system and I think make some huge improvements. Thank you.
I was very impressed by your presentation, what you're trying to do. I was very keen to see that you're going to have some flexibility in it, because it was apparent back in 2006 that the new dental contract was a disaster waiting to happen, and sadly it has, and you've now been given the responsibility of picking it up. So I wish you well of that.
Thank you.
I will certainly note it. Felixstowe is a dental desert, even though it's on the coast, and hopefully things might be addressed there, and some of the dentists may be encouraged to come back and give more of their time to it. What